We're going to be diving deep into the protective layers, the stabilizing folds, the absolutely crucial drainage networks, and of course, the vital fluid system that keeps your brain healthy and suspended.
And this is such fundamental anatomy, but it's often the stuff that gets overlooked until something goes horribly wrong. When most people think about the brain, they're thinking about, neurons and complex circuits.
Right, the flashy stuff.
Exactly. But the systems we're covering today, the meninges, the fluid dynamics, this is the ultimate structural engineering project. These are the brain's shock absorbers, its internal scaffolding, and its critical plumbing network. And we have to understand this architecture down to the millimeter because, well, that's often the difference between a minor injury and a full-blown neurosurgical crisis.
So let's unpack this vast territory. We're going to move from the tough external wraps right down into the inner fluid chambers. Our sources are just packed with highly specific terminology, so our goal isn't just to name the parts, but to really explain how these structures interact to create this closed, high-stakes system. We want you, the listener, to finish this deep dive with a crystal-clear visualization of how your brain is protected and, why that protection can sometimes fail so dramatically.
And we have a clear path to do that. We'll begin with the foundation, the 3 concentric membranes, or the meninges. Then we'll examine the dural partitions, which I like to think of as internal seatbelts for the brain.
That's a good way to put it.
From there, that leads us into the valveless channels of the dural venous sinuses, and we'll take a really close look at the critical neurovascular intersection known as the cavernous sinus.
The infamous cavernous sinus.
The very same. And finally, we'll map out the 4 chambers of the ventricular system, detailing how cerebrospinal fluid, or CSF, is constantly produced, how it circulates, and then how it gets absorbed. It's really a journey into an incredibly dynamic and finely balanced environment.
All right, let's get started. We begin where the protection begins, with those 3 concentric sheaths that envelop the entire brain and spinal cord. They suspend the brain, they cushion it, and they provide the infrastructure for blood supply. So what are these 3 layers, starting from the outermost, the layer with the most attitude?
That would definitely be the dura mater, which literally translates to tough mother.
I love that name.
It's perfect for it. Then, working our way inward, we have the arachnoid mater, which is named for its spiderweb-like appearance. And then finally, the pia mater, which is the delicate, intimately clinging innermost layer. Together, these 3 membranes are absolutely essential for containing the vital cerebrospinal fluid, providing mechanical protection against trauma, and ensuring the whole system has structural integrity.
So let's focus on that dura mater first. If you've ever seen this tissue in a lab, you know the name is deserved. It is fibrous and just formidable.
It is the defining mechanical layer. It's largely a cellular, composed mainly of these densely packed bundles of collagen fibers that are arranged in laminae, which makes it remarkably strong and, importantly, inelastic.
So it doesn't stretch?
Not really, no. Now, the cranial dura has a critical complexity that's different from the dura that surrounds the spinal cord. In the cranium, it actually consists of 2 distinct layers that are mostly fused together.
And this dual-layer structure, that's what makes the dura so functionally adaptable, right? It lets it serve multiple roles at once. What are those 2 layers?
They are the outer endosteal layer and the inner meningeal layer. So the endosteal layer is essentially fused right to the inner surface of the skull bones. It's the periosteum of the cranium, and it adheres tightly and has a really rich vascular network.
Okay, so it's stuck to the bone.
Right. And then the inner meningeal layer is the true protective membrane of the brain and spinal cord itself.
So if they're fused together for most of their run, where do they separate? And why is that separation so important for this system we're describing?
Well, they separate in 2 critically important functional areas. First, they split to create these channels for venous blood to flow. And these are the dural venous sinuses, which are housed between those 2 layers.
Got it. So they're not veins in the traditional sense. They're channels in the dura.
Exactly. And second, the inner meningeal layer folds inward upon itself to create these large partitions that stabilize the brain within the skull. We'll get into those in a bit, but these infoldings divide the cranial cavity into distinct compartments. So you see, the dura isn't just a wrapper, it's a container, a drainage channel, and an internal scaffold, all at the same time.
I was really struck by a detail in the source material, noting that the dura is the major source of pain inside the skull. We always hear that the brain itself doesn't feel pain, so why is this tough protective layer so highly sensitive?
That's a crucial distinction. The brain parenchyma, the functional tissue of the brain, is completely insensitive to pain. But the dura is extensively innervated. It receives sensory nerve fibers primarily from the trigeminal nerve, or cranial nerve 5.
All three branches.
Yeah, specifically its ophthalmic, maxillary, and mandibular divisions, which spread out across the anterior and middle cranial fossa. And then furthermore, the dura in the posterior cranial fossa, near the cerebellum and brainstem, that part is innervated by branches from the upper cervical spinal nerves C1 through C3.
Wow. So what's the clinical implication of that complex innervation?
It means that stretching, displacing, or tearing the dura, which is what happens with a mass lesion, or a rapidly expanding hematoma, or just increased intracranial pressure, that is what causes intense head pain. And it's often localized to the specific region where the dura is under stress.
So that's why a headache can feel like it's in a specific spot.
Precisely. This complex innervation explains why the pain associated with conditions like meningitis or certain types of brain tumors is just so profound. The dura is, in effect, the brain's immediate painful alarm system.
Okay, moving inward past the dura, we encounter the arachnoid mater. This is described as a thin avascular membrane. What does avascular tell us about its role?
Well, avascular means it lacks its own blood supply. It's a very delicate but resilient membrane that lies immediately deep to the dura. Its main function is really to form the outer boundary of the space where the CSF circulates.
The subarachnoid space.
Exactly. And the outermost layer of the arachnoid is characterized by having these really tight cellular junctions, which makes it a critical barrier. It prevents CSF from leaking out into the subdural space. It's like a specialized internal waterproofing membrane.
And its name, the spiderweb layer, that relates to its connection to the inner layer, the pia.
Exactly right. The arachnoid mater is linked to the pia mater by these numerous fine, thread-like structures called arachnoid trabeculae. These fibrous bands cross the fluid-filled gap, and that's what gives the subarachnoid space, the space between the arachnoid and the pia, its characteristic spiderweb appearance under a microscope. These trabeculae also provide mechanical support, helping to suspend the major cerebral blood vessels within the CSF.
Okay, and finally, the most intimate layer, the pia mater. It clings to every single curve and fissure of the brain.
It really does. The pia mater is extremely delicate. It's composed of a layer of highly specialized flattened cells. We call them leptomeningeal cells, and it's often only 1 or 2 cells thick. And they're joined by desmosomes and gap junctions. It literally invests the surface of the brain and spinal cord, following every single convolution, every sulcus, every fissure.
So you couldn't peel it off cleanly.
No, if you were to try and peel the pia mater, you would damage the underlying neural tissue. It's essentially glued to it, cell by microscopic cell.
So it's not just a wrapper then, it's a functional interface, especially where blood vessels have to penetrate the brain.
That's its critical regulatory role. The pia mater separates the external CSF environment, which is in the subarachnoid space, from the internal fluid environment of the brain parenchyma itself. So when blood vessels dive into the brain tissue, the pia actually follows them for a short distance, forming this little fluid-filled channel known as the peravascular space, or the Virchow-Robin space. And the integrity of the pia here is thought to regulate the diffusion of molecules and metabolites between the interstitial fluid of the brain and the CSF. So it suggests it plays an indispensable role in waste clearance and fluid homeostasis within the central nervous system.
And embryologically, the pia and arachnoid share a common history, right?
Yeah.
They're often grouped together as the leptomeninges.
They do. They arise from the same population of cells. And functionally, the pia also contributes to CSF production. It joins with the ependymal lining in the roofs of the third and fourth ventricles to form the tela choroidea, which is the connective tissue foundation for the specialized structures that manufacture CSF.
All right, understanding those 3 layers allows us to define the 3 crucial spaces that are between them. And in neurotrauma, identifying which space is bleeding or collecting fluid, well, that's the first step in saving a life. So let's start with the outermost, the epidural space.
So in the cranium, the epidural space is normally a potential space.
What does that mean, potential space?
It means it only exists under pathological conditions. Normally, it's not there. It's located between the inner surface of the skull bone and the outer endosteal layer of the dura mater. And because that dura is so strongly stuck to the skull, it requires a significant amount of force to strip it away.
And when that force involves arterial trauma, we get a rapidly developing emergency.
The classic example is the epidural hematoma. This typically results from a traumatic skull fracture that lacerates the middle meningeal artery. And since this is an artery, you're talking about a high-pressure bleed.
Right.
The blood rapidly pools between the skull and the dura, forcefully peeling the dura away from the bone. This swift, high-volume collection of blood creates a rapidly expanding mass lesion that compresses the underlying brain tissue. It often presents with a classic lucid interval, where the person seems fine for a bit, followed by rapid deterioration. It's a true surgical emergency where every single minute counts.
That concept of speed is really the key takeaway that differentiates it from the next space inward, the subdural space.
Right. The subdural space is also generally a potential space, and it's located between the inner meningeal layer of the dura and the arachnoid mater. And the tragedy of the subdural space is that it's traversed by these vital yet incredibly delicate veins.
What are those veins and why are they so vulnerable?
We're talking about the bridging veins. These veins have to cross the subarachnoid and then the subdural spaces to drain the cerebral cortex and empty into the dural venous sinuses, especially the superior sagittal sinus.
So they're stretched between the moving brain and the fixed dura.
Exactly. Any rapid acceleration or deceleration, and this can be a relatively minor fall in an elderly person, can cause the brain to shift just slightly inside the skull. And that shift can stretch and tear these veins as they bridge that gap.
And since these are veins, not arteries, the resulting subdural hematoma often behaves very differently than an arterial bleed.
Precisely. The blood is venous, which means the pressure is much lower, and the accumulation of blood is usually a lot slower. This can lead to chronic subdural hematomas, where symptoms, things like confusion, headaches, or gait disturbances, develop insidiously over days, weeks, or even months.
Which makes diagnosis much more challenging.
So much more challenging. And that's why subdural hematomas are often more common and are associated with a higher mortality rate, partly because they're just harder to spot quickly.
And finally, we arrive at the subarachnoid space.
Yeah.
This is the only one of the three that's a genuine fluid-filled space in a healthy brain.
That's correct. It's located between the arachnoid and the pia, and this is the main circulatory pathway for cerebrospinal fluid, the CSF. And critically, this space also houses the major cerebral arteries and veins, which are suspended by those arachnoid trabeculae we talked about.
So what makes this space clinically significant in terms of, say, spontaneous non-traumatic events?
Well, the subarachnoid space is the site of most non-traumatic hemorrhages. The major arteries that feed the brain, particularly at the base of the skull, are located right here. So if a congenital weakness in a vessel aneurysm ruptures, arterial blood is immediately dumped into the subarachnoid space and it mixes with the CSF.
And that causes the worst headache of your life.
That's the classic description, yes. It's a sudden thunderclap headache caused by that high-pressure blood irritating the surrounding meningeal layers and displacing the brain.
And as a reservoir, how much CSF are we actually talking about here? What's the volume?
In a healthy adult, the total circulating volume of CSF in both the ventricles and the subarachnoid space is approximately 150 milliliters. And that volume is maintained in an extremely tight homeostatic range. Any increase or decrease immediately affects the pressure dynamics, which is why the structures containing the fluid are just so critical.
All right. We've established the dura as this tough outer wrapper. But as you mentioned, if the brain were just loose inside that shell, any rapid movement would cause catastrophic internal damage. The dura solves this by folding in on itself to create a rigid internal scaffolding.
That's right. These dural partitions, which are just folds of the inner meningeal layer, divide the cranial cavity into these stable, non-moving compartments. Their function is purely biomechanical, to limit excessive brain movement and rotation, especially under acceleration or deceleration forces. They effectively protect it against injury.
We have four major partitions. Let's start with the largest and probably the most famous, the falx cerebri.
The falx cerebri is an impressive crescent-shaped sheet of dura. It lies right in the sagittal plane, running along the midline of the skull. Its primary role is to partially separate the two massive cerebral hemispheres.
And what defines its boundaries? Where does it attach?
It has some pretty complex attachments. Anteriorly, it attaches to the crista galli, which is a small upward projection of the ethmoid bone at the base of the skull. And then posteriorly, its attached margin blends seamlessly with the structure we call the tentorium cerebelli. Its free lower margin then curves downward over the corpus callosum.
And it also serves as a housing unit for two of the most significant drainage channels we just discussed.
It does. The massive superiorly running superior sagittal sinus is contained right within its attached convex margin, and then running along its free lower concave margin is the smaller inferior sagittal sinus. The rigidity and the size of the falx directly support the structural integrity of these two vital sinuses.
Next up, the tentorium cerebelli. This is often visualized as the anatomical roof over the structures in the lower back of the skull.
That's a perfect way to think about it. The tentorium is a large, C-shaped horizontal septum of dura mater. It creates the most significant anatomical division in the skull. It separates the large, superiorly located occipital and temporal lobes of the cerebrum.
This is the supratentorial compartment.
Right, the supratentorial compartment from the structures below it, the cerebellum and the brainstem, which are in the infratentorial compartment.
This division is obviously critical for surgical planning and for understanding pressure dynamics. But the tentorium isn't a solid sheet, is it? It has a key opening.
It does. That opening is the tentorial incisura, or the tentorial notch. And this bottleneck is an essential aperture that allows the midbrain and other ascending structures, including major arteries and nerves, to pass from the lower posterior fossa up to the cerebrum. The attachment of the tentorium itself is complex. It runs circumferentially from the occipital bone all the way to the petrous temporal bone.
The third fold is much smaller and less structurally dominant.
That's the falx cerebelli. It's a small, sickle-shaped projection that's situated inferiorly, lying just beneath the tentorium. Its function is to partially separate the two cerebellar hemispheres. Its posterior attachment is to the internal occipital crest, right at the back of the skull.
And rounding out the quartet is the smallest, but maybe the most protective fold, the diaphragma sellae.
The diaphragma sellae is a tiny horizontal shelf of dura, and its only job is to form a roof over the sella turcica, which is the bony depression that cradles the pituitary gland.
So it's a little tent for the pituitary.
Exactly. It functions as a protective shield, preventing pressure changes from impacting the pituitary. And it's perforated by a small central opening, the foramen diaphragmatus, which allows the pituitary stalk, or the infundibulum, to pass through, maintaining that connection between the pituitary and the hypothalamus.
So the structural stability provided by these partitions is generally a huge benefit. But in the context of mass lesions or swelling, these rigid divisions become the mechanism of catastrophic injury. We're talking about herniation.
Yes. Herniation occurs when increased pressure from a mass lesion, like a large hematoma or a tumor, in one compartment forces the soft brain tissue to displace and shift through one of these natural dural openings. And the tentorial incisure is, without a doubt, the most critical bottleneck for this reason.
What happens when brain structures are pushed through that tentorial incisura?
This often leads to something called uncal herniation, where the innermost part of the temporal lobe, the uncus, is squeezed past the edge of the tentorium. And because the brainstem, which controls all essential life functions like consciousness, breathing, and heart rate, passes through that same notch, the herniating tissue quickly compresses those brainstem structures.
And this compression has immediate, often fatal consequences.
Indeed. Compression of the brainstem, particularly the midbrain, damages the reticular activating system, which leads to a rapid loss of consciousness. It can also compress the vital centers that regulate breathing. Furthermore, uncal herniation often involves compression of the oculomotor nerve, cranial nerve 3, which leads to a classic dilated, fixed pupil on the side of the lesion.
A blown pupil.
The classic sign. This displacement is a rapid-onset neurological disaster that requires immediate surgical decompression. The rigidity that normally provides stability becomes a crushing force once the internal pressure exceeds the system's tolerance.
All right, now we transition from the solid protection to the crucial plumbing system that's embedded within that protection. The dural venous sinuses. These are venous channels, but they are architecturally unique.
They truly are. They're channels that are formed by the separation of the endosteal and meningeal layers of the dura mater. So they're essentially tubes woven right into the tough fabric of the meninges. Structurally, they differ fundamentally from typical veins. They lack the smooth muscle walls you'd find in most veins, and most critically, they lack valves.
And that lack of valves is the anatomical detail that transforms these sinuses into such high-stakes structures. What does the absence of valves imply functionally?
It means that blood flow is not strictly unidirectional. The flow can actually reverse depending on pressure gradients, for instance, during straining or coughing or even just changes in posture.
A two-way street.
A two-way street. And this has two major clinical consequences. It allows blood to shunt between cranial and extracranial circulation, and more ominously, it creates pathways for infection to travel against the normal flow direction, moving from external structures right into the cranium. Their overall function is to collect almost all of the venous blood from the brain, the skull, the meninges, and the orbit, and ultimately drain it into the internal jugular veins.
Okay, let's follow the flow, beginning with the major collector running along the top edge of the falx cerebri, the superior sagittal sinus, or SSS.
The SSS is massive. It runs along the attached convex margin of the falx cerebri, starting anteriorly near the crista galli, and is expanding as it travels posteriorly until it reaches the confluence of sinuses. It acts as a major drainage route for the superior cerebral surface, receiving numerous superior cerebral veins. It also receives blood from the bony channels, the diploic veins, and from the meninges themselves.
And beyond just blood drainage, the SSS is also the brain's main waste recycling center.
Yes. This is where the structural anatomy of the dura interacts directly with the fluid system. The arachnoid villi and granulations, these specialized projections of the arachnoid layer, protrude through the dura and empty directly into the SSS. This is the primary and largest highway for the absorption and recycling of cerebrospinal fluid back into the venous circulation.
So without this big high-flow channel, the constant production of CSF would just rapidly overwhelm the system.
It would, instantly.
Okay, running parallel, but along the free lower edge of the falx cerebri, is the inferior sagittal sinus, or ISS.
But ISS is considerably smaller than the SSS. It collects blood mainly from the medial surfaces of the cerebral hemispheres, and it has a relatively short run. It terminates by merging with another significant vessel, one that bears a historical name: the Great Cerebral Vein of Galen.
The Great Cerebral Vein of Galen. That sounds like it belongs in ancient history. Why did the sources pair it with the inferior sagittal sinus, and what does that combination tell us about the drainage geometry?
Well, it's named after the physician Galen, who described the cerebral venous system centuries ago. The Great Cerebral Vein is actually formed by the junction of two internal cerebral veins, and it drains the deep structures of the brain, the internal white matter, basal ganglia, and thalamus.
The really deep stuff.
The really deep stuff. So when this deep drainage system, the Great Cerebral Vein, meets the more superficial drainage of the ISS, they combine to form the straight sinus.
And where is the straight sinus located, and where does it funnel the flow?
The straight sinus runs postero-inferiorly along the midline junction created by the meeting of the falx cerebri and the tentorium cerebelli. And it, too, empties its contents into that central venous hub, the confluence of sinuses. So the confluence represents the merger of superficial superior drainage from the SSS and the deep and inferior drainage from the straight sinus.
Okay, so once all that flow reaches the central confluence of sinuses, it has to move laterally to exit the skull.
From the confluence, this massive amount of collected blood flows into the paired transverse sinuses. These sinuses run laterally and slightly anteriorly along the attached posterior margin of the tentorium cerebelli, continuing the flow out towards the temporal bone.
Then we hit the final crucial curve toward the exit.
That curve is the sigmoid sinuses. They are the direct continuations of the transverse sinuses, and they take a distinct S-shaped or sigmoid course along the mastoid part of the temporal bone. This curved path is anatomically significant because it positions them perfectly to traverse the skull base.
And their endpoint marks the shift from this cranial plumbing system to the systemic circulation.
That's correct. The sigmoid sinuses exit the cranial cavity through the large jugular foramen, and as they pass through this foramen, they change their name and structure, and they become the internal jugular vein, which then descends down the neck to return the blood to the heart. This transition marks the point of no return for venous blood exiting the cranium.
And we should also note the occipital sinus in this region.
Right. The occipital sinus is the smallest of the dural sinuses, and it usually resides within the falx cerebelli. It runs near the posterior edge of the foramen magnum and typically drains up into the confluence. But importantly, it also has crucial communication with the internal vertebral venous plexus, this complex valveless network that lines the spinal canal, and that offers a subtle but significant interaction point between cranial and spinal fluid and pressure systems.
Okay, here's the part of the plumbing system that is the most high stakes, the anatomical equivalent of a poorly designed 7-lane roundabout, where one wrong turn leads to total system failure. The cavernous sinus.
It is a phenomenal structure. We have two of them, these large venous plexuses situated bilaterally, flanking the body of the sphenoid bone and the sella turcica. They're small, only about 2 centimeters long and 1 centimeter wide, but they are an incredibly dense neurovascular intersection.
So what makes this structure fundamentally different from, say, the SSS or the transverse sinus?
It's not a wide-open channel, it's more of a meshwork, a trabeculated plexus. But its most unique feature is the sheer number of critical structures that are either passing through it or are embedded in its walls. The lateral wall, for instance, which is formed by the dura, structurally supports 4 cranial nerves.
Which nerves are we talking about embedded in that fibrous lateral wall?
Okay, so from superior to inferior, we find the oculomotor nerve, CN the U, the trochlear nerve, CND, and the first two divisions of the trigeminal nerve, the ophthalmic nerve, CNV1, and the maxillary nerve, CNV2. So any injury or swelling of the sinus walls or inflammation puts immediate pressure on these nerves, affecting eye movement and facial sensation.
But the core of the danger lies in the structures that run right through the middle of the blood-filled meshwork itself. They're basically just floating in the venous blood.
Correct. And these structures are the main arterial supply to the brain, the internal carotid artery, ICA, and the abducens nerve, CNA. The ICA snakes its way through the sinus, creating what's known as the cavernous segment, and the abducens nerve runs right alongside it. So if the pressure or the condition of the venous blood in that sinus changes, these two structures, the artery and the nerve, are immediately compromised.
So where does the cavernous sinus receive and send its flow? It sounds like a central hub.
It is a central hub. It receives blood from the orbit via the superior and inferior ophthalmic veins, from the meninges via the sphenoparietal sinus and interior meningeal veins, and it also communicates across the midline with its partner on the other side. It then drains posteriorly via the superior petrosal sinus, which goes to the transverse sinus, and the inferior petrosal sinus, which goes directly to the internal jugular vein.
Let's elaborate on the clinical relevance then, starting with the dire infectious emergency, cavernous sinus thrombosis.
This is a life-threatening septic condition. The venous network that drains the face, particularly the superior ophthalmic vein, is valveless. So an infection from areas like the nose, the sinuses, or even a severe pimple in the so-called danger triangle of the face can travel retrograde along these valveless veins directly into the cavernous sinus.
And once the bacteria are inside that meshwork, they can cause a serious clot, a thrombosis.
Right. And the clot formation traps and compresses all of those critical nerves within and adjacent to the sinus cranial nerves 3, 4, V1, V2, and 6. This leads to acute, overwhelming symptoms: excruciating orbital pain, high fever, a bulging eye or exophthalmos, and paralysis of the eye muscles, which is ophthalmoplegia. The proximity of all these nerves, coupled with that direct infection pathway, makes this an incredibly high-risk emergency.
And the other crisis involves the internal carotid artery itself, leading to a mechanical and vascular catastrophe.
That would be the carotid-cavernous fistula. Due to severe trauma or sometimes a spontaneous rupture, the high-pressure wall of the ICA breaks down inside that low-pressure cavernous venous plexus, so arterial blood is instantly jetted directly into the venous pool.
What's the consequence of dumping high-pressure arterial flow into a low-pressure venous system?
It dramatically and suddenly increases the pressure within the cavernous sinus. And since the sinus drains the orbit via the ophthalmic veins, that high pressure is immediately transmitted back to the eye. The classic clinical presentation is a massive, sudden, pulsating swelling of the eye pulsating exophthalmos, often accompanied by a loud bruit, a rushing sound you can hear near the eye, which reflects the turbulent arterial blood mixing with the venous blood. It requires immediate endovascular intervention to repair the leak.
Wow. Okay, to complete the picture of this intricate drainage, we have a network of smaller connecting channels.
Right. So starting near the front, we have the sphenoparietal sinus, located along the lesser wing of the sphenoid bone, and it serves as an inflow channel draining into the cavernous sinus. Then we have the critical outflow routes. The superior petrosal sinus runs along the superior border of the petrous temporal bone and links the cavernous sinus to the transverse sinus.
And the inferior petrosal sinus.
It takes a more direct route out. It runs via a groove in the petrous temporal bone, and the inferior petrosal sinus connects the cavernous sinus directly to the internal jugular vein, bypassing the confluent system entirely and exiting through the jugular foramen. Functionally, these two petrosal sinuses ensure complete drainage of that critical cavernous sinus area.
And deep in the midline, we find the basilar venous plexus.
This is a network of communicating veins situated between the two dural layers overlying the clivus, which is the slope of bone leading down to the foramen magnum. It connects the two inferior petrosal sinuses and, crucially, links into the internal vertebral venous plexus. And this connection is functionally important as it allows for rapid pressure equalization between the cranial and the spinal venous systems.
And finally, the marginal sinus.
This sinus encircles the foramen magnum itself, and like the basilar plexus, it communicates directly with the internal vertebral venous plexus and drains into the internal jugular vein. This entire network at the base of the skull really underscores the fluid continuity and the pressure responsiveness between the head and the neck, all facilitated by these valveless veins.
We've spent a lot of time on the venous drainage from the brain, But now we must look at the arterial supply to the protective layers themselves, and then revisit those infamous valveless connections that risk spreading external infection inward.
Right. While the brain parenchyma is supplied by the major carotid and vertebral arteries, the dura mater requires its own dedicated blood supply. And the source material highlights that the dura is primarily supplied by the middle meningeal artery, or MMA, which is a major branch of the maxillary artery, itself a branch of the external carotid artery system.
So let's trace the route of the MNA into the cranium.
The MMA enters the cranial cavity through the foramen spinosum, which is a small opening in the sphenoid bone. Once it's inside, it immediately branches, running superolaterally, and it typically divides into two major branches, the frontal or anterior branch and the parietal or posterior branch, which then ramify across the inner surface of the dura.
And this artery-specific location is what makes it so terrifyingly relevant to head trauma. It's the critical source of bleeding for epidural hematomas.
Absolutely. The MMA runs in the deepest part of the epidural space, right between the bone and the dura. Its vulnerability is maximized where it crosses the pterion. Now, the pterion is a key anatomical landmark on the side of the skull. It represents the meeting point of four bones, the frontal, parietal, temporal, and sphenoid bones.
And the bone is particularly thin there.
Exactly. It's often described as the weakest spot in the side of the head, so a blow to the temple can easily fracture the skull and lacerate the underlying MMA.
So trauma to the pterion equals a high-risk, high-speed arterial bleed into the epidural space.
That's the equation. The force required to cause the fracture is the force that tears the artery. And because the MMA is an artery, the resulting hematoma rapidly strips the dura from the bone, creating that devastating mass effect we discussed earlier. Understanding the MMA's path and its relationship to the pterion is just fundamental to neurotrauma management.
The meningeal veins tend to run parallel to the arteries, but the complexity arises in these specialized venous channels that bridge the outside world to the inside world. Let's start with the diploic veins.
The diploic veins are essentially drainage channels that are embedded within the marrow, or the diploe, of the skull bones themselves. They're large, thin-walled, and they serve to link the meningeal veins, the dural sinuses like the SSS or transverse sinus, and the veins on the scalp. They help manage pressure equalization within the bone structure itself.
But the true highway for external risk, the one allowing infections to migrate inward, are the emissary veins. These are the structures that should make us most cautious about superficial infections.
Yes, the emissary veins are small channels that traverse the entire thickness of the cranial bones, connecting the veins on the outside, the scalp, face, and neck veins, directly to the internal dural venous sinuses. They're found across various parts of the cranium, such as the mastoid region, parietal regions, and near the foramen magnum.
And the defining feature of these veins that turns a localized infection into a potential intracranial crisis.
They are completely valveless. As the source material explicitly emphasizes, this means they provide a crucial two-way street for blood flow. So if there's an infection in the mastoid air cells, which is mastoiditis, or a severe infection on the scalp, the bacteria can travel inward along the emissary vein against the normal flow, carrying infectious material directly into the dural venous sinuses.
And this is the primary anatomical route by which extracranial infections can spread to the cranium, potentially causing severe conditions like life-threatening venous sinus thrombosis or even meningitis.
Precisely. If, for instance, a clot forms in the sigmoid sinus due to an infection tracking inward from the mastoid region, this impairs venous drainage from the brain. The resulting venous congestion and increased intracranial pressure can lead to headaches, swelling of the optic disc, and potential hemorrhagic infarction of brain tissue. This valveless nature of the emissary veins is a crucial anatomical detail that really highlights the interconnectedness of superficial and deep circulation.
We've encased the brain and provided internal stability and comprehensive drainage. Now we move inside the brain substance itself to the ventricular system. This is the specialized network of interconnected fluid-filled chambers, the brain's built-in hydraulic system, where cerebrospinal fluid is produced and circulated.
Right. The ventricular system is a series of four connected chambers extending from the cerebral hemispheres all the way down to the central canal of the spinal cord. It's highly complex, and its shape reflects the C-shaped development of the cerebral hemispheres around the midline structures. And the fluid in these chambers provides buoyancy and cushions the brain, reducing its effective weight from about 1,500 grams down to around 50 grams.
Wow. We begin with the largest chambers, the lateral ventricles. There's one in each cerebral hemisphere.
They are massive C-shaped cavities that largely follow the curvature of the caudate nucleus and the developing cerebral cortex. They're structurally complex. Each one is composed of a central body and three distinct projections, or horns, which reflect the lobes of the brain they penetrate.
Okay, let's detail those horns, defining their path.
We have the anterior horn, which projects forward into the frontal lobe, and it's limited anteriorly by the genu of the corpus callosum. Then there's the highly variable posterior horn, or occipital horn, which projects backward into the occipital lobe. Its size and shape can differ significantly even between the two sides of the same person.
And the inferior horn is particularly important for surgeons accessing deep brain structures, I imagine.
It is, yes. The inferior horn, or temporal horn, curves downward and forward into the temporal lobe, and it follows the contour of the hippocampus. It ends anteriorly near the amygdala, about 2.5 centimeters from the temporal pole. And because the hippocampus and amygdala are often targets for epilepsy surgery, understanding the exact geometry of this horn is critical to avoid accidental entry or damage to vital memory structures.
The lateral ventricles then connect to the next stage of the journey via a pair of openings.
These are the interventricular foramina of Monro. They are small yet vital passageways that connect each lateral ventricle to the singular median third ventricle. They act as the bottleneck for CSF exiting these largest chambers. So any blockage here causes unilateral or bilateral hydrocephalus in the lateral ventricles.
So the third ventricle is a single median structure, often described as slit-like in shape, situated deep in the center of the brain.
It's positioned exactly in the midline. It's bordered laterally by the medial surfaces of the two large thalami and the hypothalamus just below them. The roof of the third ventricle is formed by this thin, specialized tissue called the tala choroidea, which is the underlying foundation for the choroid plexus here. And its floor contains critical structures like the optic chiasma and the infundibulum, the pituitary stalk.
So this ventricle serves as the central converging point for the fluid coming from both lateral ventricles, and is the point where the flow must be consolidated for the next narrow passage.
That's right. The posterior boundary is partially formed by the posterior commissure. The third ventricle is narrow, but its precise location surrounding those crucial diencephalic structures, the thalamus and hypothalamus, means that any expansion due to a blockage can rapidly impair consciousness, endocrine function, and sensation.
And its exit point leads into the most vulnerable structural choke point in the entire system.
That would be the cerebral aqueduct of Sylvius. It is a small, narrow tube that passes through the midbrain, connecting the third and fourth ventricles. The source material notes its diameter is tiny, often only 1 to 2 millimeters across.
And why does its minimal size represent such a massive clinical danger?
Its narrowness just makes it the single most common site for obstructions in the ventricular system. Any small mass tumor, gliosis, or congenital stenosis, a narrowing from birth, can easily plug this tiny tube.
And if that happens?
If the aqueduct is obstructed, the CSF that's produced in the lateral and third ventricles can't exit. This leads to a massive, rapid accumulation of fluid and pressure buildup, which is known as obstructive hydrocephalus. This is frequently lethal if it's not immediately relieved.
Once the CSF manages to navigate the aqueduct, it enters the final chamber, the fourth ventricle.
The fourth ventricle is a diamond-shaped cavity, and it's situated between the cerebellum posteriorly and the brainstem, the pons, and medulla anteriorly. It then tapers caudally to connect with the central canal of the spinal cord.
So this is the end of the line for internal circulation. The fluid has to exit here to begin its external circulation and eventual absorption.
The fourth ventricle is the crucial gateway. The CSF must pass out of this chamber and into the surrounding subarachnoid space. And this requires 3 specific apertures in its roof: the unpaired central opening, the median aperture, foramen of Meninges, and the paired openings on the sides, the lateral apertures, foramina of Luschka. These 3 foramina represent the critical link between the internal fluid system and the external fluid cushion.
Okay, let's dedicate some time now to the fluid itself. Cerebrospinal fluid, or CSF. This clear, colorless liquid is arguably the single most important element in the brain's protective environment. It's providing cushioning, nutrition, and waste removal.
CSF is often described as an ultrafiltrate of blood plasma, but it's actively transported and modified, which results in a very unique composition. It's normally very low in protein, it's virtually cell-free except for a few lymphocytes, and it differs significantly in ion concentrations compared to plasma. And this precise composition is absolutely essential for neural function.
And the source of this constant, regulated supply is the choroid plexus. What exactly is this structure?
The choroid plexus is a specialized vascular structure. It's a network of rich capillaries that are covered by specialized epithelial cells called ependymal cells, and they're located within the ventricles. These structures are present in the lateral, third, and fourth ventricles, with the most massive plexus residing within the temporal horns and the bodies of the lateral ventricles.
And the production process is constant, requiring this enormous turnover rate to keep the system clean and buoyant. What is the daily production rate?
The CSF is produced constantly and relentlessly at a rate of approximately 500 milliliters per day. And this is an astonishing figure when you recall that the total volume of CSF circulating in the ventricles and the subarachnoid space is only about 150 milliliters.
That rapid turnover means the entire fluid cushion is replaced multiple times a day.
The total CSF volume is replaced roughly 3 to 4 times every 24 hours. This rapid production and clearance are essential. It provides the necessary buoyancy for the brain. Without it, the brain's own weight would crush the cranial nerves and the lower blood vessels. It also serves as the major metabolic sink, constantly flushing waste products out of the brain's interstitial fluid.
And the choroid plexus also operates a critical barrier function, doesn't it?
Yes. The epithelial cells that cover the choroidal capillaries are linked by tight junctions, and this creates the blood-CSF barrier, which tightly controls what substances can pass from the blood into the newly formed CSF. This is separate from, but complementary to, the blood-brain barrier, and it ensures the chemical stability that's required for neuronal signaling.
Let's follow the flow again, just to cement the pathway through the 4 chambers.
Okay, so the journey begins in the lateral ventricles. It passes through the paired foramen of Monro into the third ventricle. From the third ventricle, it's channeled through that narrow, crucial cerebral aqueduct and then into the fourth ventricle.
And once it's in the 4th ventricle, the fluid has to leave the internal system and enter the external subarachnoid space for circulation around the brain and spinal cord.
And that exit relies on the 3 apertures in the roof of the fourth ventricle. The single central median aperture, foramen of Magendie, which opens into the cisterna magna, and the paired lateral apertures, foramina of Luschka, which open near the cerebellum-pontine angle. If these openings are blocked, due to a congenital malformation or inflammation, it causes non-communicating hydrocephalus, trapping the fluid inside the ventricular system.
Once the fluid exits the 4th ventricle, it spreads throughout the entire subarachnoid space. But in certain areas, the arachnoid and pia separate widely, creating these large reservoirs of CSF known as subarachnoid cisterns.
Yes, these cisterns are reservoirs that accommodate volume shifts, and they house critical neurovascular structures. They are major landmarks in neuroimaging and surgical approaches.
What's the largest and most important one?
The largest is the cisterna magna, or the cerebellomedullary cistern. It's located between the inferior surface of the cerebellum and the posterior surface of the medulla. It's the first large reservoir the CSF enters after exiting the Magendie aperture, and it's a common site for accessing CSF for analysis, for example, in a cisternal puncture.
And we have key cisterns surrounding the major arteries and nerve roots at the skull base.
That's right. For example, the pontine cistern lies anterior to the pons, and it contains the basilar artery. The intrapeduncular cistern is situated between the cerebral peduncles, and it holds the circle of Willis arteries. The chiasmatic cistern is anterior to the optic chiasm. And then the cistern of the lateral sulcus, or Sylvian cistern, is located laterally following the lateral fissure, and it contains the middle cerebral artery.
So functionally, we have cisterns at the major exits, like the cisterna magna, and then cisterns surrounding critical arteries and cranial nerves at the skull base. This localization provides cushioning where the most vital vessels are located.
The volume capacity of these cisterns helps to buffer acute pressure increases, and that provides the brain with vital seconds of protection during rapid changes in intracranial dynamics.
Now, the maintenance of this constant low CSF pressure is vital. If intracranial pressure, or ICP, rises too high due to a blockage or a mass, it can have immediately observable effects outside the cranium, specifically on the eye.
This is a classic example of anatomy-informing pathology. The dura and the arachnoid layers extend forward, and they form a sheath that surrounds the optic nerve all the way to the back of the eyeball. So therefore, any rise in CSF pressure is transmitted directly to this sheath.
And how does that pressure translate into visual symptoms?
Well, inside the optic nerve sheath, the CSF pressure begins to squeeze the delicate central retinal vein as it enters the nerve from the eyeball. This compression impairs the venous return from the retina, Think of it like a high-pressure hose sheath squeezing a delicate pipe, the vein running inside of it.
Right.
The resulting venous congestion leads to fluid leakage and swelling of the optic disc, which is visible upon examination as papilledema.
So papilledema is not just a symptom. It's one of the most direct, observable clinical signs that the pressure dynamics inside the cranium are severely disturbed.
It connects the minute mechanics of CSF pressure directly to a life-threatening neurological condition. And if this compression is chronic, it can eventually impair axonal transport in the optic nerve, leading to permanent vision loss. It just emphasizes the fragility of the entire system.
We established the staggering production rate of 500 milliliters of CSF per day. Now, if the contained volume is only 150 milliliters, the system must have an incredibly efficient and rapid recycling plan to prevent immediate, catastrophic fluid buildup.
The mechanism of absorption has to precisely balance the rate of production, or the brain would be instantly overwhelmed. And this crucial process is maintained primarily by specialized structures that are dedicated to returning CSF back into the dural venous circulation.
Tell us again about the primary mechanism of absorption, the arachnoid villi and granulations.
These are specialized structures. They're protrusions of the arachnoid mater that physically penetrate the inner dural layer and project directly into the lumen, or the internal channel, of the dural venous sinuses, especially the superior sagittal sinus.
And we distinguish between the microscopic villi and the larger granulations.
Correct. The villi are the microscopic structures. They're numerous and widely distributed. The granulations, also known as pachyonian bodies, are the macroscopic collections of these villi. They're often visible to the naked eye, particularly in the parasagittal lacuna adjacent to the SSS. And these granulations frequently undergo calcification later in life, making them dense and prominent in older individuals.
So how do they manage to siphon off hundreds of milliliters of fluid daily without allowing venous blood to reflux back into the subarachnoid space?
They function effectively as highly sophisticated one-way valves. The mechanism relies on a pressure gradient. So under normal conditions, the hydrostatic pressure of the CSF in the subarachnoid space, which is typically 7-15 millimilli Hg, is slightly higher than the venous pressure inside the SSS. This pressure differential drives the CSF to flow down its gradient, filtering or actively transporting the fluid from the subarachnoid space directly into the venous blood.
A one-way gate.
Exactly. They ensure the venous blood stays out while the CSF flows in.
So the CSF absorption process is intrinsically linked to the function and patency of the dural sinuses.
Entirely. If venous pressure within the SSS is excessively high, like in certain heart conditions or thrombosis, the pressure gradient disappears or even reverses, which slows or stops CSF absorption. This is one cause of communicating hydrocephalus, where the ventricles are open, but the fluid just can't be absorbed properly.
We mentioned the subarachnoid trabeculae earlier as a kind of spiderweb scaffolding. Do they play any functional role in fluid dynamics beyond just suspension?
They're structurally crucial. They're composed of these fine connective tissue fibers, collagen and fibroblast-like cells that suspend the cerebral blood vessels and neural structures within that CSF bath. And while their primary role is mechanical stability, they also create the characteristic meshwork that the CSF has to navigate as it flows toward the absorption sites in the SSS and the cisterns. The configuration and density of this meshwork directly affect the resistance to CSF flow within the subarachnoid space.
The absorption isn't limited just to the SSS, though. What are the secondary drainage routes for CSF?
While the arachnoid villi are the dominant route, CSF also drains along the sheaths of cranial and spinal nerves. And this is particularly significant for the olfactory nerves, cranial nerve 1, which pass through the cribriform plate into the nasal cavity. The CSF follows the nerve sheath and is thought to be absorbed into the lymphatic channels of the nasal mucosa.
So that's a direct link to the lymphatic system.
It is. It's the only known point where the CSF system interacts directly with the lymphatic system, and it offers a crucial secondary pathway, which is especially important in situations of high ICP.
And the final secondary route is the paravascular spaces, those channels you mentioned where blood vessels penetrate the brain tissue, lined by the pia mater.
Yes. The traditional view saw these paravascular spaces as just passive channels, but modern research suggests they are far more active. These spaces, often called Virchow-Robin spaces, are believed to be instrumental in the clearance of interstitial fluid from the brain parenchyma. The CSF traveling through these channels may serve as the fluid conduit that washes metabolic waste products out of the brain tissue and back toward the absorption routes.
And the sheer volume of this fluid exchange suggests this system must be chemically and structurally robust. The sources suggest that our understanding of CSF absorption is moving beyond simple pressure-dependent filtration toward complex biological transport.
That's the current frontier of research. While the pressure differential provides the bulk driving force, electron microscopy and cellular studies suggest that the arachnoid granulations involve specialized cellular elements, mesothelial cells from the arachnoid cap, and endothelial cells lining the sinus. And this implies complex active transport mechanisms are at play, possibly involving large vacuoles that shuttle fluid across the cells rather than just simple passive filtration.
So how does this sophisticated machinery hold up over a lifetime? What happens to CSF dynamics as we age?
The anatomical reality is that the quantity and size of arachnoid granulations actually increase throughout life. However, they also undergo degenerative changes like hyalinization and calcification. They essentially harden over time.
Get less efficient.
Exactly. And the source material notes that this potentially impaired efficiency in the elderly may contribute to changes in CSF dynamics.
This link to aging is especially relevant given the rise of neurodegenerative diseases.
Well, if the absorption mechanism becomes less efficient due to age-related degeneration of the granulations, the delicate pressure balance is disrupted. This is one of the hypothesized mechanisms behind conditions like normal pressure hydrocephalus, or NPH, which affects the elderly and presents with a characteristic triad of gait difficulty, dementia, and urinary incontinence.
So the ventricles are dilated, but the pressure isn't necessarily sky high.
Right. The CSF pressure may not be grossly elevated, which suggests a chronic issue with maintenance and absorption rather than an acute blockage. The effective recycling of this high-volume fluid is a continuous, high-stakes job, and when the machinery wears out, the systemic neurological consequences are profound.
The continuous high-volume production and complex recycling 500 milliliters replaced daily remind us that this system is not static. It's incredibly dynamic, and its health is directly linked to the brain's ability to clear waste.
Absolutely. The fluid is constantly being replenished, constantly moving. It acts as the brain's lymph system, effectively. And the structural elements we've detailed, the meninges, the dural partitions, the sinuses, are all designed to support this continuous, critical physiological process.
That was an exhaustive and, frankly, awe-inspiring deep dive into the infrastructure of neurological protection. We've synthesized a massive amount of detailed anatomy today.
We started with the protective shield of the tough dura mater and its complex two-layer structure, which not only provides structural stability but also houses the drainage channels and is the primary source of head pain. We then mapped the stabilizing partitions, the falx and the tentorium, which prevent brain movement but which also create the lethal bottleneck for transcompartmental herniation under pressure.
We tracked the drainage, focusing on the intricate, valveless, and high-stakes plumbing of the dural venous sinuses, emphasizing the critical neurovascular complex of the cavernous sinus, and the risky valveless pathways provided by the emissary veins that connect external infection sites directly to the cranial interior.
And finally, we explored the dynamic hydraulic system, the four interconnected chambers of the ventricular system, where the CSF is constantly produced by the choroid plexus at an astonishing 500 milliliters a day, circulated through the narrow cerebral aqueduct, the key structural choke point, and then recycled back into the venous blood via the specialized cellular machinery of the arachnoid villi in the superior sagittal sinus.
The overall takeaway is just profound. The brain is suspended in a precisely regulated fluid cushion, encased within a rigid, internally stabilized container. Every minute detail we covered, from the dense innervation of the dura to the specific anatomical vulnerability of the middle meningeal artery at the biuterion, is critical to understanding the narrow window of neurological health. You now have a comprehensive functional map of this vital system.
But before we wrap up, let's revisit that final structural connection we detailed. We established that CSF is absorbed via the dural sinuses, but we also noted that the subarachnoid space communicates with the paravascular spaces, the Virchow-Robin spaces, that surround blood vessels penetrating the brain parenchyma. So if the pia mater acts as a regulatory interface between the CSF flow and this internal interstitial fluid clearance system, a network often referred to now as the glymphatic system, and we know the pia mater is essentially glued to those penetrating vessels.
What does that suggest about the structural support needed for that waste clearance to occur?
Exactly. If the flow of CSF through these paravascular spaces is the primary driver for washing metabolic waste, like amyloid beta protein, out of the brain, how might age-related degeneration or disruption of the pia mater's structural integrity impair this clearance mechanism? This suggests a direct structural link between the health of the meninges and the ability of the brain to literally wash itself clean. And it raises the provocative question: Could the physical pathology of the pia mater and the perivascular spaces be a significant, overlooked contributor to the progression of major neurodegenerative diseases like Alzheimer's? It's a structural anatomy question with billion-dollar implications for future therapeutic targets.
That is certainly a dense, detailed, and utterly critical connection to leave you with. Something to mull over until our next deep dive.